Hello to everyone, and a warm welcome to this OMRON-sponsored satellite symposium, Navigating the Patient-Driven World of Cardiac Recordings. My name is Gregory Lip. I'm Professor of Cardiovascular Medicine at the University of Liverpool in the United Kingdom, and it's a great pleasure and honor to chair this satellite symposium. So by way of introduction to our speaker, let me set the context. These are my declarations of interest. I'm not going to read every line, but to put into context whatever I say or speak in this presentation with these declarations. Our program today is to start off with a few opening remarks, which is now, and I'm just to give a very short overview of the status, particularly related to atrial fibrillation screening and detection and in the ESC guidelines. We will then move on to the formal presentation by Associate Professor Keitaro Seno from Kyoto in Japan on new tools for atrial fibrillation screening and its clinical relevance. We will then have a short period at the end of this satellite symposium on question and answer. So please include the Q&As for a healthy discussion at the end of this session. Our speaker today is Associate Professor Keitaro Seno, and it was a great privilege and honor that actually Keitaro was with me in the University of Birmingham in 2014, and it's a great pleasure to work with Keitaro again. Presently, he is senior lecturer in the Kyoto Graduate School of Medical Science in Japan, and it's a great pleasure to be able to have him here with us today. Let me set the scene for the importance of atrial fibrillation detection. And if you think about the risk assessment and management of patients with atrial fibrillation, if you look at any textbook of cardiology from the last decade, the chapter on atrial fibrillation covers things like stroke prevention and the importance of thromboprophylaxis. In atrial fibrillation patients, we deal with management of symptoms largely, and this brings into the discussions rate control, rhythm control. Recognizing that AF patients are very often elderly with multiple comorbidities is to manage the risk factors, the comorbidities, and as well as increasingly the lifestyle type changes. And these are the so-called steps for a patient pathway or the patient journey to manage atrial fibrillation in an integrated or holistic manner. But let's face it, even before the patient gets into this management pathway, we need to improve our detection and our awareness and our characterization of atrial fibrillation patients, because it's all very well having this management pathway, but if we don't improve our detection of atrial fibrillation patients, we're not going to get there. I wish to draw attention to this ERA consensus document. This is essentially a overview and of the aspects of screening for atrial fibrillation, which can range from very simple things like pulse palpation and symptom detection, as well as monitors, patches, sophisticated monitoring, smartware, and of course implantable loop recorders in relation to improving our detection of atrial fibrillation. But you can sum this up by you look harder, you look longer, you look in more sophisticated ways, you are likely to pick up more atrial fibrillation. And this is reflected also in the new 2020 European Society of Cardiology guidelines for the diagnosis and management of atrial fibrillation. It takes a very patient-centric approach because, after all, AF is so common, managed by general practitioners, many non-cardiologists, non-specialists, as well as cardiologists, and even within the cardiology department, non-arrhythmia specialists and arrhythmia specialists. And the whole diagnosis and management of AF pathway is summed up as CC to ABC. And CC, firstly, you see, it starts off by confirm the diagnosis, make sure that you document the arrhythmia, then you can start the assessment and treatment. Characterize the atrial fibrillation. This is part of our holistic evaluation of the patient atrial fibrillation. And what do? These are things that we are doing in everyday practice. We assess stroke risk. We have the CHESVAS score. We assess symptoms, and we have the ERA score. We assess the severity of AF burden and characterizing whether it's paroxysmal AF and the temporal relationship of atrial fibrillation arrhythmias. And then we, of course, have substrate severity reflecting age and comorbidities. And after the CC, you go into the treatment, which is the ABC pathway. Simple as ABC. A, avoid stroke, or A is anticoagulation, where the default is stroke prevention unless they're low risk, and then the preference is with a NOAC. and also to importantly to address modifiable bleeding risk factors in these patients. B refers to better symptom control, which is patient-centered, symptom-directed decisions on rate or rhythm control. And then finally, C, comorbidities and cardiovascular risk management, including lifestyle type changes, including the patient's psychological morbidity. And essentially, that really, CC to ABC, sums up what's within the new 2020 ESC guidelines for the diagnosis of atrial fibrillation. But the diagnosis and management, and even before you start the management and the patient pathway, we require the diagnosis. And with that, those are my introductory remarks. Let's move on to the presentation by Dr. Senu for this session. Thank you.
Hi, hello everyone. I'm Keito Senu, and I'm from Kyoto Prefectural University of Medicine. Today, thank you for watching our presentation. Today, I would like to talk to you about the new era in AF screening at home. And my title is New Tools for Atrial Fibrillation Screening and its Clinical Evidence. This is my COI. An early diagnosis of atrial fibrillation may have several benefits, including individualized lifestyle intervention and anticoagulation, and may be associated with reduction in complications and healthcare cost. And as you can see, the variety of monitoring tools are developed for now. The left side shows smartwatch companies, and right side shows other devices such as handheld or patch EKG companies. And the importance of early diagnosis has been recognized in recent ESC guidelines, which recommended opportunistic screening using pulse palpation and EKG rhythm strip in persons older than 65 years old. So how about each tool's performance? According to the published data, all tools have achieved high sensitivity and specificity for atrial fibrillation detection. And for example, the single lead EKG sensitivity is about 94 to 98%, and the specificity is 96 to 95%. Like single lead EKG, the smartphone apps, which means PPG, and the smartwatch, same as single lead EKG, have also achieved high sensitivity and specificity. And recently, more and more companies are developing deep learning models to improve device performance. And for example, this is a BeatLogic platform for EKG interpretation, and this study validated the platform using electrophysiologist-adjudicated real-world data and publicly available validation data. And deep learning models were trained to perform beat and rhythm detection and classification using EKGs collected with the Preventis Body Guardian heart monitor. And beat detection sensitivity was 99.7%, and atrial fibrillation sensitivity is more than 96%. And the sinus sensitivity was 97%, and the VT sensitivity was 97%. So, the technology company like Preventis solution appears one after another, and advances in EKG interpretation by the AI algorithm has moved on to the next stage. And today I'd like to briefly talk about the performance of complete wireless upper arm blood pressure monitor with EKG paired with an automated rhythm adjudication AI algorithm for the detection of atrial fibrillation, which is made by OMRON Healthcare Company. And the patient were instructed to perform twice blood pressure measurements, and 30-second EKG recordings of bipolar lead 1 rhythm strip by touching the electrodes located on the top face and both sides of the monitor. And if a recording could not be interpreted as normal or possible atrial fibrillation, the patient were instructed to perform another measurements. Within 2 hours of the measurements with the complete devices, 12-lead EKG recordings were obtained. This series of processes was performed before and after the ablation during the patient hospitalization. And baseline characteristics and measurement data of the study population are listed in Table 1. And to test the accuracy of the complete automatic algorithm for detecting possible atrial fibrillation, the sensitivity and the specificity for detecting the possible atrial fibrillation were 100% and 86%. To assess the fidelity and overall quality of complete rhythm recordings and transmission, the physician interpreted complete recordings and the 12-lead EKG were compared, and the sensitivity and specificity were 99% and 85% respectively. And now, so we are doing multi-center prospective observational study by using this blood pressure monitor with EKG. The study population is 100 persistent atrial fibrillation patients undergoing catheter ablation. The primary endpoint and the secondary endpoint are listed in this table. I'll briefly explain our study protocol. In the study, 100 persistent atrial fibrillation are enrolled and followed up for 1 year after ablation. The primary endpoint is the time to atrial fibrillation detection in comparison with the usual care during the follow-up. And the secondary outcome is an agreement between the OMRON device and the standard Holter EKG monitor performed every 3 months. The patients are routinely followed up in clinical practice because the result of the device are blinded to both the patients and the clinicians. And we have completed all the patient registration and are now following up those patients. And we, KPUM Education Initiative, have been holding a disease awareness symposium since 2019, and more than 1,600 elderly people aged more than 65 years old participated. In the symposium, participants measured blood pressure and EKG with a complete and answered questions about atrial fibrillation knowledge and received atrial fibrillation indication. The objectives were first, early detection of stroke risk, which means detection of new onset of atrial fibrillation and suboptimal blood pressure. And second, the educational activities, which means the survey on understanding of atrial fibrillation and the satisfaction with educational activities. The number of registered participants were 1,648, of which 1,607 were included in this analysis after excluding 41. And a participant background is shown in the table on the right, and the average age of the study group were 72 years old, with 51% females, and average CHADS-2 score of 0.9 points, and an average CHADS-BASC score of 2.5. Of the 1,607 participants, 58 had atrial fibrillation and 15, 0.93%, had newly diagnose atrial fibrillation confirmed by physicians. The number needed to screening for one newly diagnosed atrial fibrillation was 106. And let me show you the new detection of atrial fibrillation in subjects with or without hypertension. As you can see in this table, the new atrial fibrillation was found more in subjects with hypertension, 1.59%, and compared with those without hypertension, 0.51%. And the diagnostic yield of screening programs can be enriched by targeting population with the high prevalence of atrial fibrillation, particularly the elderly and those with more than one risk factors for atrial fibrillation, such as hypertension. And this slide shows the prevalence of hypertension and detection of atrial fibrillation by blood pressure values on the day. The white bar shows the hypertension history, and the light green bar shows the suboptimal blood pressure, which means systolic blood pressure more than 114 or diastolic blood pressure more than 90 on the day. And the green bar in the AHA-ACC 2017 shows the systolic blood pressure 130 to 139 or diastolic blood pressure more than 80 to 89. The number of hypertension patients based on the JCS guidelines was more than 60% of all participants and more than 80% based on the AHA-ACC guidelines. There was no significant difference in the detection of new atrial fibrillation among subjects with normal blood pressure and suboptimal blood pressure. And these questions are the results of the questionnaire taken before the educational lecture. It's easy to see that most participants don't know much about atrial fibrillation, but after that, we gave a 30 minutes educational lecture on atrial fibrillation and finally conducted the questionnaire survey. So this is the last question for the participants. More than 99% of the participants were satisfied with our activity. The summary results of the questionnaire indicated their participation of the significant educational value of the symposium. During the atrial fibrillation awareness campaign using the moderate number of possible atrial fibrillation and suboptimal blood pressure control cases were identified. This event should take advantage of the opportunity to provide education on the atrial fibrillation and stroke prevention, thereby increasing their benefit to all participants. With the advent of smart technologies like something I introduced today, early atrial fibrillation detection has become possible. But however, on the other hand, this paper by Dr. Marcus raised an alarm over screening for atrial fibrillation using smartwatches and pointed out that a tech company like Apple has bypassed expert consensus to initiate screening for atrial fibrillation in the general population. The left side shows conventional workflow for the research output, and the right side shows workflow involving wearable technologies. As you can see the right figure, due to the direct marketing by tech company to patients and the general public, they consume information and approach clinicians for appropriate information. Therefore, this report says that there are several additional steps in the workflow for the use of wearable technologies to detect atrial fibrillation are urgently needed. So how do the healthcare providers are actually seeing wearable detected atrial fibrillation feel about the current situation? According to the survey of the healthcare professionals by AF Screen International Collaboration, The referral to physicians of patients for clinical evaluation after atrial fibrillation detection through wearable devices or apps in more than 50% of cases was related to patient self-referral or was prompted by a primary care physicians. And this slide shows important disadvantages in mass community screening using wearable devices. Around 65% of respondents worried about anxiety in people with the positive test, and also 41% of respondents concerned false assurance in case of a negative test. What should we consider for the proper use of advanced technology? What action should be taken against the lay public and the healthcare provider? I'd like to suggest what we should do. We clinicians and researchers should conduct the highest quality research to inform both the lay public and all the healthcare providers. We also need professional society consensus statements that are specifically intended for the lay public on the subject of wearable detected atrial fibrillation, and the talks and forums for the lay public should become a higher priority. Beyond simply enhancing the pretest probability, these efforts can also help lay individuals understand what AF is and what to do about it, and why. And for the primary industry, machine learning also certainly has an important role in the interpretation of the smartwatch-derived data. So they should develop the AI algorithm to improve device performance. And they should be socially responsible for the influence of the technology on the market and share information between us. Now, this is the last slide. As I mentioned today, atrial fibrillation screening via these technology tools will probably promote early atrial fibrillation diagnosis. However, whether wearable itself leads to a reduction of stroke incidence is another issue. But since there are reports showing the relationship between lower medication adherence and increased stroke and mortality risk, medication adherence is an important issue in reducing stroke risk after atrial fibrillation diagnosis. So we have developed atrial fibrillation apps, providing educational videos for atrial fibrillation knowledge and reminder email for keeping drug adherence and collecting personal health records. And I hope atrial fibrillation apps and consumer EKG devices should be used together to reduce stroke risk and optimize treatment. Thank you for your attention.
Thank you very much, Kentaro, for that really excellent presentation. And I think that it does raise a lot of aspects or perspectives with regard to the screening of atrial fibrillation, especially monitoring of risk factors such as blood pressure. Now, please just encourage our audience just to submit questions online, and we have a number of questions coming through, and I think it's important just to put into perspective because there's lots of screening initiatives, and of course we have a proliferation of medical devices that are detecting atrial fibrillation, and you've highlighted some of the challenges there with regard to how device detection and screening would be useful. However, does this translate to outcomes? And I suppose, Kentaro, what clinical evidence would you like to see going forward? Because as you quite rightly point out, many companies have developed apps, they've developed smartware. Some, as I said, seem to have more data compared to the others. So if we can have perhaps just your take-home message, what evidence do we need? Translation to hard clinical outcomes or objective management strategies?
Okay, thank you for your question. So it's very hard to answer that question. So then the main point is the hard endpoint, like mortality or the heart failure incidence or something like that. So, and stroke as well. In the previous study, maybe the ASAT study, there was a 2.5-fold increase in the risk of a stroke or systemic embolism in patients with the episode of the asymptomatic atrial high rate episodes compared to non-atrial fibrillation. This is not the device-detected atrial fibrillation, but it's a little bit similar to the device-detected atrial fibrillation etiology. So, of course, I don't know whether the same level of risk will be seen in those individuals who have the silent variable detected atrial fibrillation as a result of screening in the general population, but it's a hard endpoint, the stroke risk and the heart failure incidence of rate and mortality as well.
Okay, no, I think those are great points. You mentioned the Apple Watch study, of course. I mean, that was a community screen. The mean age in the Apple Watch study was 44. I mean, that's not the category of age where we anticipate particularly high risk of AF complications. Because of course, smartware, watches, and new tech, the younger people in the population are more inclined to go for that. So I'll be very interested in your perspective, because obviously in Japan, the mean age of the population, there's a lot of elderly AF patients. So it'd be nice to get your perspective on the technology sort of differences,
Yeah, I think it's necessary to identify appropriate target, as you said. For example, in case of patient with, for example, high CHADS2 score, like a CHADS2 score more than 2 points, for example, older age and hypertension or other modifiable stroke risk factors, and also having the repeated symptoms like palpitations, dyspnea, or something like that. So those patients, I would recommend some intervention based on the device-detected atrial fibrillation. So I think appropriate patient selection would be, yeah.
Yes, and I think one of the few positive things from this pandemic is that there's more telemedicine, there's more remote monitoring platforms, and I think we're going to see over the next 5 to 10 years more and more of patients monitoring blood pressure, monitoring their health, and of course the opportunity to have atrial fibrillation detection with smart devices. If you wish to have a crystal ball and look into the future in the next 5 to 10 years, are you going to see? Do you think we're going to see more and more of this remote monitoring platforms for measuring blood pressure, for measuring atrial fibrillation, and all that?
Yeah, thank you. Yeah, thank you very much. Thank you for your question. So, I think hypertension and atrial fibrillation, they are very common chronic and recurrent conditions with an unmet needs for the disease tracing and the diagnosis. And I think in the near future, the monitoring disease-related metrics through such multifunctional blood pressure devices through the remote monitoring, as you say, so will be essential in assessing the effectiveness of treatment and the disease management. Thank you.
Well, I think that's been a great discussion, Kitara, and I think time is upon us now. And I think the useful take-home messages clearly is that as technology is advancing, you've seen some of the novel data from Kitara, from the OMRON system for monitoring not only for atrial fibrillation, but also blood pressure. But I think that's really important as we move forward towards an increasing use of smart technology and telemedicine. I think that it has been a really helpful and useful discussion. Thank you very much for participating, and enjoy the rest of the Congress. Thank you to everybody.
Thank you.